Pregnancy is supposed to be one of the most exciting times in a woman's life, but for some women, it comes with additional health risks. A San Diego woman is sharing her very personal story with us today and the medical challenges she faced before becoming a new mom. I'm Stephanie Simmons, and this is the backstory of high-risk pregnancies. Joining me now is Dr. Tevi Tith, a maternal fetal medicine specialist. That is quite a title, but you do good work. So thank you for being with us and breaking this all down, because there's a lot of information, and this subject can be very scary for women who want to be pregnant as it is. So getting all that information out there helps ease women's minds. So let's first start with the basics then. Tell us what is all involved in a high-risk pregnancy.
So maternal fetal medicine is a subspecialty of obstetrics and gynecology. The physicians are double boarded in both obstetrics, gynecology, and then maternal fetal medicine, so high-risk pregnancies. High-risk pregnancies can be anything that involves maternal medical comorbidities, so things like chronic hypertension, diabetes, and in Sydney's case, renal transplants. It can also involve things like fetal abnormalities as well. So certain babies are born with abnormalities, genetic abnormalities, and there can even be placental abnormalities as well that can place the woman at high risk.
So let's go into categories here. Let's start with the mom, because there's a lot of information to digest. And by the way, Sydney is the woman, Dr. Tith's patient, who we will be speaking with a little bit later on in the show. So hang tight for that, because her story is crazy, but as you just heard, it ends with a happy ending. Okay, so let's talk about the mom. Pre-existing conditions. Do these pre-existing conditions necessarily mean this pregnancy is going to be bad and not always a great outcome?
No, absolutely not. Pre-existing conditions vary according to what the patient's condition was prior to the pregnancy. If the pre-existing condition was well controlled, if the patient was otherwise healthy and is getting a good care, and if a pregnancy is discovered and diagnosed early, the maternal fetal medicine physician or the obstetrician can help her mitigate those risks during the pregnancy.
Okay, let's talk about age first and foremost, because women are starting their families much later in life, and it's just a thing. We heard this scary title of geriatric moms and geriatric pregnancies. By the way, I technically was one, became a mom at 34. How high risk does that make a mother or an expecting mother when it comes to age, and what is the age where you would put them in the high risk category?
So we would call them advanced maternal age.
That sounds classier and less scary too, Dr. Tith. I like that better.
I try not to use geriatric. I don't think it sounds very nice.
Tell me what the new way is now.
Just advanced maternal age.
Advanced maternal. I'm advanced maternal. I like this. We're going with that.
I mean, truly, it's just anybody who is 35 years or older.
Okay.
And it really very much depends on also the health of the mother. Advanced maternal age, just being over 35, it can potentially increase your risk of things like chronic hypertension, also diabetes, certain predisposition to having clotting disorders during the pregnancy. But most patients who are otherwise healthy actually have a really great chance of having a normal pregnancy as well.
It doesn't have to be all bad or scary. You just have to have extra monitoring, right?
Absolutely.
Okay. What is chronic hypertension for people who don't know?
Chronic hypertension is where your blood pressures are high, are higher than normal, and some patients have to take medication for this in order to help decrease the load or the strain on the heart. Mm-hmm. Because as pregnancy advances and progresses, it's kind of like putting your heart under this extra stress, and chronic hypertension can just sort of increase that stress over time and over the development of the pregnancy.
Is that just history, like family history, or is that, are we talking about smokers here, someone who's overweight?
For
For the high blood pressure?
For the high blood pressure, no, those are patients who, a lot of times they'll have a history of chronic hypertension in their family.
Okay.
And there are obviously secondary causes of chronic hypertension as well, such as underlying kidney disorders. So those things can increase your risk of developing chronic hypertension. But yes, definitely weight can increase that risk. Smoking can also increase those risks as well.
Okay. Okay, so a woman is pregnant and she didn't automatically qualify as high risk to start because we're not talking about pre-existing conditions. Let's talk about what can develop during the pregnancy, like gestational diabetes.
Absolutely. So gestational diabetes is actually something that we're finding more and more commonly developing in pregnancies. It's almost as common as it's like 1 in 8 pregnancies are developing gestational diabetes, and it's really because the population as a demographic is starting to become more obese and putting on more weight prior to getting pregnant. Gestational diabetes occurs typically because the placenta, it's an organ, it secretes hormones. Its job is actually to keep the baby alive, and so the placenta is one of the mechanisms that occurs to do that is that it increases your blood sugars, and this happens because the blood sugar transfers over to the baby, and then it's part of the baby's nutrition, and it can increase so much that it increases mom's blood sugars in pregnancy.
Okay, so we're going to talk in a little bit about monitoring, but I want to get through a little bit more of these conditions first. So have you seen the movie Steel Magnolias?
No.
Okay, it's very dated reference, but Julia Roberts, I believe, had diabetes, and they told her not to get pregnant. She delivers a healthy baby, and then things go wrong afterwards. So with diabetes, if someone has type 1 or type 2, they deliver a baby. We'll stay on the diabetes subject for a second. Do you worry, are they high risk not only pregnancy but post-pregnancy?
Absolutely. So patients who start with gestational diabetes, they have about a 50% risk of developing diabetes after the pregnancy. And it may be immediate, but a lot of times it's kind of this peek into the future where you know that you're at risk for developing diabetes because you have some form of impaired glucose tolerance. And so I kind of, when I counsel patients, I tell them it's both a blessing and a curse because it is unfortunate that they have to check their blood sugars and monitor the growth of the baby, but also it's kind of a window of opportunity to make changes to your lifestyle during the pregnancy and then postpartum in order to help decrease that risk.
I love that you said that. Okay, so if someone was originally in the high risk category for whatever reason, they could potentially, depending on the condition, reverse it during pregnancy or post?
They would develop, well, we wouldn't change that diagnosis. It's more just a way of modifying your habits, modifying lifestyle to help decrease those risks and ultimately end up with a successful pregnancy.
Okay, so the big three, would you say, are high blood pressure, diabetes, and then kidney disease or kidney issues?
Those are definitely risk factors that can influence and impact the health of the pregnancy, the development of adverse pregnancy outcomes, and yes, they do tend to be the most common.
Okay, so Sydney, your patient who we'll be speaking with in just a few minutes, tell us about her condition and why you had to pay extra special attention to her.
So Sydney had a double renal transplant about a decade ago. And because of the renal transplant, she had to be on multiple anti-rejection medications. And you can't really stop those anti-rejection medications in the pregnancy. So we had to monitor her for kidney function. We had to monitor her for an increased risk of infection. Because of the impaired kidney function, Sydney also had chronic hypertension as well, and then there was also anemia that we had to worry about. There were multiple things that we had to think about for Sydney in order to really try to optimize the pregnancy for as long as possible.
Okay, so Sydney was high risk day one. When you're talking about the monitoring process, how does it evolve during the trimesters?
So during the trimester, again, we sort of have to separate it into maternal monitoring and then fetal monitoring. Maternally, we were looking at her kidney function through baseline labs, protein in the urine, blood pressure. And then for the baby, we were monitoring Avery's growth throughout the pregnancy. And ultimately, we had to admit Sydney into the hospital for closer monitoring of both mom and baby.
And when did that happen?
Around 32 and a half weeks or so. I was really worried about the symptoms that Sydney was developing and then the increasing blood pressure. And I was worried about preeclampsia in the pregnancy.
Which you hear a lot as far as high-risk pregnancies. Does kidney function alone, when when a woman is pregnant, does that put extra stress on our kidneys?
Yes. Even in a normal pregnancy, the kidney function has to increase substantially because there's so much more blood that is retained in pregnancy. So the kidney has to function to filter through all of that. So even normal pregnancies, that is something that happens.
We'll get Sydney's take on this as well, but you're responsible for the science and medical part of keeping your patient, as well as possible and, the best outcome as possible. What do you do for the mental aspect? Because I'm sure people like Sydney herself, but other patients as well, it's incredibly scary with a high-risk pregnancy, especially a first one.
Just having, encouraging as much support at home, but also really being their cheerleaders as well as physicians, and in that monitoring, making sure that the patient has really clear and realistic expectations of the pregnancy so that they're as prepared as possible.
Okay, just we have to take a break in a second, but just another question for you. So we talked about the pre-existing conditions, what can turn a pregnancy high risk during, and then you touched on this, but I want to ask another question, baby's health. So what have you seen during a high-risk pregnancy where there's extra stress on baby? What has caused that, and how did you prevent that from getting any worse?
So extra stress on the baby can manifest itself in things like placental insufficiency, decreased fluid, decreased growth. And so we end up trying to balance it with as much monitoring and pushing the pregnancy as far along as possible, and then ultimately deciding whether or not to deliver the baby.
Okay, and how early could you deliver a baby successfully with all of the medical advancements we have now?
We usually use 24 weeks as our
Wow.
point or threshold for viability, but at Sharp, I do know that there are pregnancies that are viable that we've delivered even before that. So 23 weeks, although I think we were pushing that, yeah.
Wow, but that has to be so stressful for the mom, but to deliver a baby, a baby who is alive and living and being able to do that this day and age is incredible. Okay, thank you, Dr. Tith. We're going to hear more from you in just a second, but we are going to take a quick break, and after the break, we will hear from Sydney Sachs and her incredible story and her journey to becoming a mom for the first time. Stay with us. Welcome back, everybody. Joining me now is Sydney Sachs, who herself had a high-risk pregnancy. I had this big intro I was going to read about you, Sydney, but I want to hear it straight from you. Your story is incredible. I think you should write a book. But first of all, before we get into this craziness, people at home are going to say, what? This is not a scene of a movie. This is your incredible life full of love. You are a new mom, so we will meet Avery in just a second.
Yes.
So there is a happy, healthy outcome to all of this. But okay, tell us your story, because you have lots of sisters. So let's start there and what happened with, I guess at birth, you were already high risk into adulthood and wanting to be a mom.
Yeah, so I'm one of 7 girls in my family. My parents had 3 girls, 8, 6, and 2, and then I'm one of 4. I'm a quadruplet as well. So definitely a surprise for them.
And it was not planned.
Not planned. Yeah, no in vitro. Yeah. Mm-hmm.
That's a house full of hand-me-downs, and God bless your dad.
Yeah. And mom
Hello,
as well,
girl,
yeah.
dad. Yes, and mom. You're going to hear a sweet part of this story in just a second. I actually, as I was reading up on the research of your story, I was telling you before the show, I teared up, and then I was telling you about it, and I teared up again. It is just so sweet. So, okay, let's talk about the high risk. So you came out 3rd.
Yes.
And at 28 weeks.
Yes.
And they told your mom what about your condition?
Me specifically, that I was the smallest preemie. I was 1 pound, 12 ounces, and that my kidneys were not functioning or not working as well. So I stayed in the NICU for 3 months after being born. And we were all in the NICU, but I was there the longest.
So this sets you up for a life of having to monitor your kidneys, right?
Yes and no. So after I was in the NICU and they're like, oh, baby's kidneys are working. Great, you can take her home. And then nothing to worry about really throughout the years until I was 19 and I was in kidney failure. So basically going home, being told that my kidneys were fine, nothing really to look out for until there were symptoms we now know growing up.
What symptoms did you have?
I had chronic fatigue.
As a teenager.
Yeah,
so that's
teenager.
Something to flag. Okay.
Yeah. I was a picky eater. Even though a lot of kids are picky eaters, I specifically was picky with like protein and just more thirsty than normal and just fatigue and really just picky with the protein when I was a kid.
And it makes sense now. I probably missed, as you were growing up because that's not normal to catch.
Yeah.
So tell us this sweet story about your parents are just such wonderful people. So you were going into kidney failure, but your parents stepped in to help.
Yes. So when I was told kidneys were already failed, so at that point doing biopsies and tests to figure out exactly what was going on. They saw that they were very scarred and just working a lot harder, so they also underdeveloped. They didn't grow full term. They say maybe, I believe, about till I was 10. They grew to like the age of 10. And then from there, slowly like declined. And once I was diagnosed with chronic kidney disease, then we knew where to go from there with transplants.
So your dad gives you one?
Yes, he gave me my first kidney when I was 21. And that was just a blessing and very thankful that I didn't go through the normal steps that some may need to go through with dialysis before I was able to go straight to transplant with him.
And then that lasted several years, but eventually you needed another one.
Yes, that one failed, I believe, six years after transplant. And then I did go on dialysis for just about a year and then received another transplant from my mom.
You got me again, Sydney.
Yeah.
And so this is the one. So you have your part of your mom with you, and now you're a new mom yourself. So let's jump. We have limited time. I could talk to you all day about this. Let's jump to motherhood for you. So you get pregnant, and you knew you were going to be high risk going into the pregnancy.
Yes.
So Dr. Tith tells you you're at high risk. What happens then, and what was the monitoring like?
So before I went to the hospital, monitoring was just lab tests, checking on the pregnancy, growth of the baby, and monitoring blood pressure, medications that I'm taking as well after transplant. Just very frequent visits. Yeah.
And you were also admitted to the hospital very early. How many weeks along were you, and what did they tell you as to why you needed to go to the hospital that early in your pregnancy?
I was about 32 weeks, and I was going in for a normal checkup for non-stress tests, which all moms do. And I had cleared the stress tests, and then my blood pressure had spiked, and Dr. Tith came in and was like, okay, we're going to admit you and monitor you closely.
Okay, so was this a bed rest situation for the rest of your pregnancy? Were you working at this time?
I was not working,
Okay.
and it wasn't bed rest. I was monitored in the room, but I was able to get up and like move around, go on walks, things like that.
The mental aspect of this, because you hadn't had a child before, and with everything leading up to this, you knew you were high risk. How did you stay calm? Because just for moms who don't have high risk pregnancies, we're afraid to walk, and we're afraid we're going to eat something wrong, or something's going to, it's just, carrying your first child is scary, but also exciting. How did you process that to calm yourself mentally through all of it?
Really, it was with health issues for the past decade. I felt very prepared and was very well known to Sharp. So they knew me and have taken great care of me since before I was pregnant. And just the mental strength to go through that really was, I think, Avery, because it wasn't just thinking about my own health, I was thinking about hers. And she really got me through it, and just staying calm for her health as well.
Was it so wonderful to see her checkups as well, that her heart was healthy through the process, and to see her move in your belly?
Yes, absolutely. Those were all just huge blessings that I was able to have with her.
Oh,
Yeah.
wonderful. Okay, well, we are not done yet. We need to take a quick break, but can we meet Avery after the break?
Absolutely.
Oh, this is so exciting. She's really cute. She has a lot of hair. Stay with us, and we're going to have some final thoughts as well with Sydney. Baby Avery, if she wants to talk as well, maybe give us her first words super early. And Dr. Tith. Stay with us. All right, some final thoughts with Dr. Tith and Sydney. Dr. Tith, what is the most important thing you want women to understand about high-risk pregnancies?
The most important thing to help improve your chances of a successful pregnancy is everything that happens really before, and that is to ensure that you have a healthy lifestyle, not smoking, making sure that you're seeing a physician regularly for your well women's exam, maintaining a healthy weight, and ensuring that that your health is overall good. And even if you have things like underlying comorbidities like chronic hypertension or diabetes, that you can optimize all of those things and go into it with a really healthy outcome.
Okay, that's very good advice. And Sydney, if there's a woman out there wondering and who may have a pre-existing condition like yourself, can I have a healthy pregnancy? What would you say to them?
Yes, absolutely. And like all the things that Dr. Tiz said, just checking up with your lifestyle and support, and really just being in good communication with your team, and they'll help you a lot through it.
And you had the perfect outcome. Can we meet Miss
I
Avery?
did, yes.
She is so scrumptious. Tell everyone how old
She
now.
is.
Oh my God, look at her
She
cheeks. I can't
is.
even stand it.
She is 4 months, yes, and she's doing great. She was great during the pregnancy and great after, so I'm very thankful for that, yeah.
Yes, that's a nice gift for you,
Yes.
especially all you went through leading up to it. I will tell you, though, she's not going to have any cheeks when she leaves our studio,
Yeah.
because I am going to munch them off. And she might not have any fingers or toes.
Yeah.
Okay. Much today. She's so cute. Ladies,
is.
thank you so much for being on the show. We really appreciate everything. Thank you for sharing your story with us, Sydney, too. It's very personal, and we know you helped a lot of other women. And thank you for watching. I'm Stephanie Simmons, and this is The Backstory.